Hi, my name is Kathy. I'm a pediatric respiratory therapist in the PICU. I'm going to show some kind of cover ventilators, talk about terminology, and see if I can help you kind of spot the difference between whether or not they're in volume or pressure, and kind of as a nurse what you're looking for on the ventilator. So just a quick overview, this is the 980, so this is the ventilator that we are using currently, the newest of the Puritan Bennett's. So across the top here, these first few metrics that you have, these are standard, these don't change. So you always have your P peak, your tidal volume, your frequency, which is your respiratory rate, and then your IDE ratio. Anything that's in these little boxes here that you can scroll over can actually be changed. So they may change from vent to vent. We try to keep the same ones up, but it can be customized based on the RT that's taking care of the vent that day to be all of these different values. So these can change, but know that you can scroll usually to find what you're looking for. That being said, most of the values that you're going to see on these screens are not necessarily values you're going to need to worry about as a nurse, but just so you can know. And then sometimes they'll actually have the opportunity to see a very bigger display, which has the graphics, very little, very large numbers. The idea behind this is you can see the values from across the room or outside the room or something like that if you need to. It's not often used here in our ICU, but it is an option. From left to right, this C, what the C is what type of breath the breath is. So is it a control breath, or C? Is it an assist breath, or A? Or is it a spontaneous breath, which is an S? And so right now, it's a control breath, every single breath. And what that means is that there's no effort from the patient. The ventilator is sensing no effort from the patient. Now, that doesn't necessarily mean the patient's not giving effort, because there is a setting that can control whether or not the ventilator can sense an effort. So sometimes the patient can be essentially locked out of the vent. So you may still see effort in your patient, but you're not noticing it here. That's a call to your RT. But what you'll see is that it's the control breath means that there is no effort sensed by the vent of the patient. So it is time to give a breath, so it is giving a breath. Right now the vent is set at a rate of 30, so it's giving a breath every 3 seconds. If I squeeze the bag, you'll see that it switches sometimes between an S and an A, sometimes a C. What the difference between those are is when it says A, it's an assist breath, and an assist breath means that it was time, the 3 seconds had passed, so it was time for the ventilator to give the vent breath. However, there was effort from the patient at the same time. So it is an assisted breath. It is a breath triggered by the patient, but it is delivered at the vent settings. And so usually when you see those, that's a good indication that your vent and your patient are very nicely synced. So if every single breath is an A, then that means that every time the vent wants to give the breath, the patient wants the breath. So that means that whatever your set respiratory rate is matching what the patient wants right now. So if you're looking at just the graphics, it can be hard to see that there's actually effort from the patient. And so there have been times where we have a patient, we're waiting to wake up from paralytic, the rate is still really high, and we're told, oh, the patient's riding the vent, but actually what you're seeing are assist breaths, and the patient's not actually riding the vent, and if we turn the rate down, we would see more spontaneous breaths. Now S, that's spontaneous. So what a spontaneous breath means is that the patient wanted a breath at a time that it was not time for the vent to give one, right? So at a rate of 30, a breath comes every 3 seconds. If the patient wants to breathe at 1 second or 2 seconds since the last breath, then that would be a spontaneous breath. Now, depending on the mode, that is usually your pressure supported breath. So on the graphic, they're red. And they tend to be a little bit smaller because our pressure supports tend to run a little bit smaller. But that is 100% patient effort. So that's what the C, the A, and the S means. P peak is your peak inspiratory pressure, which is the highest pressure that the breath is being delivered at. It's your top pressure. So in this case, it's 15. The VTE is your exhale tidal volume. So that is the tidal volume being read as it comes back from the patient. Frequency, F total, we talked about. That's your respiratory rate. Your IDE is a ratio of inspiratory to expiratory, not something you really need to worry about, but something we do have to pay attention to when you get higher into your rates. So if your patient's on like a 1-to-1, they don't have a lot of time to exhale, and that's kind of important. And so you have patients where their gases look like you need to turn the rate up, but what actually happens is the more you turn the rate up, the less time they have to exhale, they continue to stack their CO2, and they actually look worse. So that's a good way for us to see that, but again, that's not necessarily something that it's good to look at, but it's something your respiratory therapist really should be paying attention to also. So those are your simple graphics across the top. Now across the bottom, SIMV volume control. So this patient is an SIMV VC, which is volume control. SIMV stands for synchronized intermittent mandatory ventilation, and what that means is that the patient has an opportunity to breathe above the rate, but any breaths above the set rate are at a pressure supported breath, so it's a different setting. Sometimes you'll see, very rarely you'll see it, but usually in adults, but there is an assist control option, which is A/C, and then they'll say volume control. Assist control is the patient is allowed also to breathe above the rate here, but any breaths that are triggered by the patient are still going to be at the set volume or pressure. And so many people look at it as a very finer control because there's less variability. You don't have, like in SIMV, you'll have your large vent breaths and then your smaller pressure support breaths, but there's a lot of difference generally between the two. In assist control, every volume of the breath or every pressure of the breath is the same, and so you can almost feel like you've got a finer control over your minute ventilation with your patient. It's not necessarily the one's like better than the other or one's more comfortable than the other. Every patient's a little bit different. Every doctor's a little bit more comfortable with certain modes. Every RT is a little bit more comfortable with certain modes, and that tends to be what everybody uses, is what they're comfortable with. But I am a firm believer that if you understand a ventilator the way you're supposed to, you can interchangeably use your settings. So you can match assist control with an SIMV mode if you know what you're doing. So, but that being said, so down here at the bottom, again, it's SIMV volume control. That's one way to tell what mode your patient's in. The other way to tell is that here the setting VT is a tidal volume. So everything across the bottom of the screen here is what is set on the ventilator. So top is patient, bottom is ventilator. Okay, and so right now your frequency is set at 30. Your tidal volume is set at 90 milliliters. This Vmax is a flow. So the flow is how fast the breath is delivered. In a volume control mode, your tidal volume and your flow are set. What determines your I time is how fast the breath is. So when I actually open this up, I can see that at 17.2 liters a minute, to get to 90 milliliters, it takes 0.58 seconds. So I can determine my I time based on this, but what is actually set is your flow. Then you have your P support, which is your pressure support, your FiO2, and then your PEEP. So those are all settings that should match your order. FiO2 is ordered as titration usually, unless your patient's on very strict precautions for like over-oxygenating or under-oxygenating. Otherwise, it's titration and not specifically ordered. Everything else will match your orders. If I were to change this to pressure control, my settings change. And so now I see SIMV PC or pressure control. I still have a set frequency, but now instead of a tidal volume, I have an inspiratory pressure. So this is 15 cc's of, centimeters of water. And what this is a delta P. And so the difference between the delta P and the PIP is the PIP is the top number, the PEEP is your bottom number, and your delta P is the difference. So the test log is changing my numbers a little bit just because it's a weird, like almost an over compliant lung. So my PIP is reading at 27, which is consistent with the fact that my delta P is set at 15 and my PEEP is set at 5. If I go up on my PEEP, then my PIP is going to change to be the addition of the two. So it's going to go closer to 25. No. Yeah, this is an over-compliant one. Sorry. I'm like, wait, that's off now. But the idea is that your delta P and your PEEP are added together to get your PIP. And this is important. And there's a difference that we're seeing in the way that NICU does their ventilator settings versus the way PICU does their ventilator settings. So PICU, when they deliver their settings, they deliver it as a PIP over a PEEP. So if we were with this patient, they would tell me that they want the vent set at 25 over 10. And I would have to do the math to figure out what my vent actually needs to be set at. Because if I set this number at 25, I'm overventilating my patient. I'm giving them too much volume, and I'm potentially causing trauma to their lungs. So that's how NICU delivers their settings. PICU does deliver them as a delta P over a PEEP. So you will hear PICU order their settings as 15 over 10, for example. So understanding the difference between a PIP and a delta P is important. It's also important kind of helping you understand how the ventilator breathes for the patient. So, with that being said, the only other settings that's changed that has changed when I go to pressure control is that instead of having a flow here, I actually have an eye time. So in a pressure control mode, your control settings, your I can't think of what I'm trying to say. Your pressure and your eye time is set and your volume is variable. In a volume control mode, your volume and flow is set and your pressure is variable. And then that's the difference between the two. There are really 3 variables we're controlling. We can only control 2 at a time. There will always be one that's variable. Is there one that's better than another? I don't think so. I think that there's one that patients find more comfortable than others. I think that there may be certain situations that calls for one, but again, I am a firm believer that if you understand ventilators and the way that they ventilate, then the settings can be used relatively interchangeably. A couple other, like just a review, not necessarily anything that you're going to see on the ventilator, but just a couple other terminology that you want to remember. You want to review it from the PowerPoint that we've gone over, make some notes, whatever it is that you need to do to try to understand the terminology. Learn it over time. This is a lot of information. You don't have to take it all in now. And a lot of it will come to you as you experience it. So again, your peak inspiratory pressure is your PIP, that's your top number. Your PEEP is positive end expiratory pressure, that's your bottom number. So that is the amount of pressure left in the lungs at the end of the breath. That number also very tightly corresponds to oxygenation. So often if you have a patient that's having trouble oxygenating, you will go up on their PEEP. Your delta P, or pressure above PEEP, is the difference. It's the middle pressure, so it's the difference between the two. It's the difference between the top number minus the bottom number. Mean airway pressure is the average airway pressure across the lung. It corresponds very closely to mean arterial pressure. Not in that they should be the same, but in that the concept is the same. And so really that's another one that's important when it comes to oxygenation. It's also another one that becomes very important when we're looking at oscillators, because what an oscillator does is it finds that mean airway, that average pressure, and it vibrates at that pressure. It vibrates air in and it vibrates air out. So often when you have a patient that's getting to the point of needing an oscillator, that's when they start asking like what the maps are and stuff like that. And again, on this ventilator, it's this P mean. continuous positive airway pressure, or CPAP. We don't run a lot of CPAP or BiPAP on kids. They tend to be the older ones. We do run it on the ventilator, but the concept is the same. It's a top pressure, and CPAP is a bottom pressure. So CPAP and PEEP are the same thing. It is a bottom pressure used to stent the airways open, which is why it is a common therapy for sleep apnea. In sleep apnea, the airways collapse and the patient can't breathe. You put a CPAP on, it delivers a constant pressure to the lungs, the airways are stented open so that the patient can breathe, muscles can relax, and the patient can actually sleep. It is the exact same concept as PEEP. The only time the terminology changes is when the interface with the patient changes. So it is called PEEP when they have an advanced airway, either an ET tube or a trach. It is called CPAP if they're wearing a mask. And that's the same thing with BiPAP. The difference between CPAP and BiPAP is BiPAP has, again, a top number and a bottom number. It has a top number to assist with the inhale. It still has the bottom number to stent the airways open. And it's called BiPAP, again, when they have a mask on. And BiPAP is very similar to a spontaneous mode on here. And it's, again, really called BiPAP. If they have a mask, it's called spontaneous, or like a pressure support trial sometimes when they have an advanced airway. But the idea of the vent is the same. They're actually working exactly the same. The terminology, the pressures, all of it's the same. It's just different terminology. And unfortunately, there is no standardization of terminology. Every manufacturer has been allowed to call different concepts similar terms, which makes it very confusing. But trying to really kind of understand the concept behind it will help you not get so muddied by the names. Eye time is pretty self-explanatory. It's the amount of time that the breath goes in. So it's the inhale. There are standards for different age groups. Adults, the average is 0.8 to 1.2, things like that. But it can be very patient-specific. And then tidal volume is the amount of breath, the amount of air in each breath. Here, when we ventilate, it can be anywhere from 6 cc's per kilo to 12 cc's per kilo, depending on the condition of the patient, what we're trying to do, that kind of thing. It tends to be looked at as a cc per kilo. In the pediatric population, it's actual body weight, which is also often why your respiratory therapist will ask you what the weight of the patient is before we put them on the vent. And that's so that we have an idea what kind of tidal volume we're aiming for. In the adult population, it's ideal body weight. So we don't actually take into account what they actually weigh. We use their height to determine what would be an ideal weight for their height, and then we use that to ventilate them. And the idea behind that is that the size of your lungs is determined by your height, not necessarily your weight. And so the taller you are, the bigger your lungs are. The smaller you are, the smaller they are. But it takes out the variable of the patients that have perhaps extra weight. So you may think that they actually have bigger lungs, but they don't. They have the same size lungs, they just have more adipose tissue on the outside of it. So you don't want to be ventilating them with more volume just because their weight is higher. So that's how adults are done. There's kind of a weird transition in teenage years on whether or not they switch, from adults away from adult. And where that switch happens from using ideal body weight to actual body weight, there's no consistency, unfortunately, in that population, because it just depends, again, on what's happening with the patient. But the thing to remember is that for lung protective strategies, what we're aiming for the most part, are lower tidal volumes. What we're finding with a lot of studies is that if you keep the delta P lower, that you've got less trauma on the lungs. And so sometimes lower delta P corresponds to a lower tidal volume. And so, again, we aim for anywhere from 6 cc's per kilo to sometimes 12 cc's per kilo.
Is that the sweet spot?
Yes, the sweet spot.
VC plus.
VC plus, yeah, so VC plus is fun. VC plus is a combination mode, and so there's been a lot of debate about whether or not pressure or volume is better. they each have their pluses and minuses. And so what it is that when you have a patient who's in a volume mode and their pressure is variable, if their lungs become stiffer, their pressures spike. And when their pressures spike, sorry, let me turn some alarms off. And when their pressures spike, you start to get into an unsafe range as far as like where you want your PIPs or your peak inspiratory pressures to be. For the most part, we like to keep them under 30. Most alarms are set at 40. If they start to get into like the mid to high 30s and higher than that, then everybody really starts to kind of be alarmed about traumatizing the lungs, understandably. I'm worried about traumatizing the lungs. And so with a volume control mode, it's trying to deliver the same volume. So if something changes in the patient's compliance, like their lungs become stiffer, if something changes as far as they've got more secretions or they go into a bronchospasm, so the muscles around the airways become tight, cranky, and irritated, and they clamp down, all of those change the ability of the